So I think we're going to move on now to the respiratory part of this, and Noah Lechtzin. Noah?
Thank you. Hopefully everybody can hear me. It's very noisy up here, so it's hard for me to hear the other speakers, but hopefully it's a little quieter in the rest of the room. That was a wonderful talk from Brian about very fundamental questions such as what causes ALS and looking at things such as stem cells. I'm a dumb pulmonologist, so I'm just going to focus on sort of a concrete issue that we're dealing with now. So as you can see, the title is Diaphragm Pacing, Turbulent or Transformative. I did not come up with the title, and at the time I was starting to put together the slides, I didn't think a whole lot about it, but the more I've thought about it, it is a bit of a turbulent issue right now. It's an exciting new therapy for ALS that shows a lot of promise, but there's some conflicting data and a lot of skepticism on the part of some clinicians, some patients, some payers, and so I think we're still wrestling with where this fits into our armamentarium. I thought I had about 10 more minutes than I actually have been allotted, so I'm going to skip through a couple slides, so don't get nervous about that. So I'm going to start with my history with diaphragm pacing, or how I met Ray Onders. So Ray Onders is a general surgeon at Case Western Reserve University who has really pioneered the current state-of-the-art laparoscopic approach to diaphragm pacing. So he came to Johns Hopkins and addressed the neuromuscular group somewhere around 2005, and because the neuromuscular neurologists knew that I was interested in ALS and we had a lot of interactions, they said, hey, you know, they're talking about diaphragm pacing, you ought to come listen to this guy. And anybody who's heard Ray talk or met him know he's a very dynamic, enthusiastic individual. And so he showed us some of his data in spinal cord patients, and he had just begun to use diaphragm pacing in a handful of ALS patients. And so he was talking about his approach and some of the theory about using electrical stimulation to the diaphragm, and that potentially you could condition the diaphragm and improve diaphragm bulk and strength. The neuromuscular group at Hopkins is a very skeptical group, and so as he was presenting this, there was a lot of back and forth about, you know, does this make any sense? Does this work? And so I came away from this conference saying, hey, you know, this sounds very intriguing, but I'm not a neuromuscular physiologist. I don't really understand these neurons. So I asked a number of my colleagues and said, hey, you know, does this make any sense? And I got a mix of answers. I had some neurologists say, no, that makes absolutely no sense whatsoever. I don't know why anybody would want to stimulate the diaphragm. I asked one of our more senior neurologists, Dan Drachman, does this make any sense? And he, not surprisingly, said, oh, yeah, sure. I did a study on this in 1972 and handed me a paper that he had published. And so this is a paper from 1972 entitled Trophic Regulation of Acetylcholine Sensitivity of Muscle Effective Electrical Stimulation. So kind of a lengthy title, but what was in the paper is a figure here of a rat diaphragm with electrodes stimulating it. And what he was able to show is that by stimulating a rat's diaphragm, you could essentially, a denervated rat's diaphragm, you could normalize some of the responses to neurotransmitters. So just one bit of early evidence that this may make some sense. This is not a new concept. People have been doing diaphragm pacing for over 25 years. The bulk of the older literature is in patients with spinal cord injuries or central hypoventilation syndrome. And so there's a company, Avery, that has been making a diaphragm pacer for quite some time. This figure shows a young man with one of these pacers. And what's different about this from the newer one is that, from the newer technique, is that this is a electrode that's implanted high up in the chest, so it requires chest surgery and some manipulation of the phrenic nerve up in the chest with an electrode that wraps around it and then gets hooked up to a transmitter. It's fairly extensive surgery. There's a lot of risk for nerve injury both at the time of surgery and then after years of stimulation. So it was really nothing that was ever initially thought of for ALS patients. That brings us to the present. So there is now a device manufactured by Synapse that's done through a laparoscopic technique, so through 1 centimeter incisions, scopes are inserted under the diaphragm, and electrodes are implanted. And so what I want to spend the rest of my talk focusing on is who's this approved for, who's it appropriate for, which may be, in my mind, probably 2 different things, some of the technical details about what's involved, and then the benefits that have been demonstrated. So this is, again, a figure. The phrenic nerves are these 2 yellow lines. They originate high up in the neck and go down alongside the heart and into the diaphragm. So these are the nerves that provide most of the innervation to the diaphragm, which does most of the work of breathing. These electrodes, you can sort of see here, there's 2 implanted on either side, 2 implanted on the right, 2 implanted on the left, and then they come out through the abdomen to an external stimulator box. So why are we talking about it now? The FDA approved this device in October of 2010. It was given what's called a humanitarian device exemption, which is a full-fledged approval of this device, but it's meant for disorders that are expected to affect 4,000 people per year or less. And it really, the approval doesn't require quite the level of evidence that other FDA approvals require. But the approval was based on both safety and probable benefit. And so there was an analysis of 86 patients, and I'll show a little bit of this that showed some benefit. So as I said, I was going to talk about indications, who's this approved for, and then who ought to be thinking about using this. So the FDA says it should be for ALS patients with a diaphragm that can be stimulated, who are experiencing chronic hypoventilation but have a vital capacity, a forced vital capacity, above 45%. So by a stimulatable diaphragm, this is definitely a key component here, you need to show that the phrenic nerve, that nerve going to the diaphragm, is working. So it can be shown either by neurophysiologic testing, so nerve conduction studies, or by simply showing that the diaphragm can work volitionally, either with fluoroscopy, so this is an X-ray that watches the diaphragm move, or ultrasound. So you have a patient do various maneuvers like sniffing, and you should be able to see that the diaphragm actually moves, either by ultrasound or X-ray. And then this other part that the FDA stipulates is that they have hypoventilation, so either a low vital capacity, and they say below 50%, but remember, it also had to be above 45%, so it doesn't leave you much of a window. And I'll talk about that in a second. A maximal inspiratory pressure, so have a patient suck in as hard as they can, and the amount of pressure that they can generate should be abnormal. Or an elevated carbon dioxide, so all of our bodies produce carbon dioxide, and when we exhale, we get rid of carbon dioxide, and if you're not moving enough air in and out of your lungs, CO2 rises, so a CO2 that's above normal. Or an oxygen saturation that's abnormally low. I'm not going to go into a whole lot of details about these things, except to say that I have a lot of issues with the term that they use, this hypoventilation, but it's what's been used by the FDA approval. To define hypoventilation, what that really means is that CO2 is elevated, and as I showed before, they're not really interested in CO2 per se, they're interested in other things, and most patients with ALS will have a very weak diaphragm well before the CO2 ever becomes abnormal. So what I want to emphasize is that we shouldn't be worrying about hypoventilation per se or CO2, and what we really need to think about is that we want patients who have very early or mild diaphragm weakness. The issue is that, as I mentioned, the idea is that you can electrically stimulate the diaphragm and condition it and improve strength and bulk of the diaphragm. If you wait too long, the diaphragm becomes scarred and fibrotic, and there's not much you can do about that. So I think we've run into real problems if we wait too long, not to mention that if you wait too long, patients are a lot less stable and surgery is more risky. So what we really need to be focusing on is trying to pick up early signs of diaphragm weakness. Another thing to keep in mind is that assessing diaphragm function and strength in ALS patients is not perfectly straightforward. There's a lot of challenges. So sometimes patients can have a lot of respiratory muscle weakness, diaphragm weakness, before they ever feel short of breath. Patients who have bulbar weakness have a lot of secretions, weakness of the mouth muscles, trouble with coordination, and that can make performing pulmonary function tests very challenging. And so sometimes we see patients who you measure a vital capacity and it says it's 30%, but they're actually fine. It's just that they can't do a good job with vital capacity. So you have to use some clinical judgment in how you interpret these findings. And the respiratory progression and the progression of ALS in general is quite unpredictable. And so it's not enough to say, well, so-and-so is doing fine now. We've got 6 months or 12 months before we need to worry about anything. So you can often be, unfortunately, surprised by how things progress. So you have to have a fair bit of suspicion and be on the lookout for these problems. I'm going to skip over this case. I was going to just show the first patient that I encountered with diaphragm pacing, but in the interest of time, I don't think it adds much, other than to say when he was diagnosed with ALS, he was a young filmmaker who was quite into shock value. So he had a website and had pictures of him sitting naked in a wheelchair protesting in front of the White House. But after he had his diaphragm pacer inserted, he had a picture of himself posing with his peg tube, getting beer poured into it. So I'm going to move on to some of the practical, technical aspects of diaphragm pacing. And so, as I said, part of this is, of the evaluation is showing that the phrenic nerve is intact and that the diaphragm is still working to some extent. This is a slide courtesy of Mary Jo Elmo, who's the nurse practitioner at Case Western who runs their diaphragm pacing program. And so one thing to do is a chest x-ray and just show that the diaphragms are elevated. But really what you want to do is then go on to either fluoroscopy, so this is a picture of fluoroscopy, or ultrasound showing that the diaphragm can move, or you could do nerve conduction studies showing that the phrenic nerve is still functioning. Because again, if you're trying to stimulate the phrenic nerve where it inserts into the diaphragm, the phrenic nerve has to be intact and working. This is just a slide showing a glimpse of what the surgical technique is like. So as I said, it's done through the abdomen, through scope, so 1 centimeter incisions. These transducers are inserted. You have one for a camera, one for a stimulator. This is an older slide. I think they've actually cut down on the number of ports that they use. But that gives you an idea of what's involved. These are pictures from the actual surgery. So the initial step is that they use a electrode with a suction cup on the end, and it goes under the diaphragm, on the underside of the diaphragm, close to where the phrenic nerve inserts. And the idea is that you stimulate through this suction cup electrode and try to find the points where you get the most stimulation, the most contraction of the diaphragm. Ray Onders was very happy. These, you can see after they've used these suction cups, it leaves little red marks, and he was very happy that he got the word hickey into the medical literature. But after they've mapped it and found where you get the most impulse, you then implant the electrodes, and then you do some test stimulation. Let's see. So there was a publication just a couple years back showing that this is, in fact, a safe surgery. So in 51 ALS patients that had diaphragm pacers implanted in Cleveland and Detroit, they all did very well. They were all able to be extubated. They were able to come off the breathing machine right after the surgery. And there were no deaths in the 30-day postoperative period. So where you would think patients would have the most complications in the first few days afterwards, nobody had anything too severe. The most common complications were things such as pain from the surgery or pain with stimulation. There are, again, as I said, this is still a new technique. There's a lot of questions that still need to be answered, and one of them is kind of what is the ideal post-implantation conditioning regimen. So in the OR, they program each of the electrodes, but there's debate as to whether you start with high stimulations and then decrease, or start off low and then increase. Ideally, or optimally, you have to find out what's going to work for an individual patient. Sometimes a patient may have pain from one particular electrode, so you have to decrease the stimulation with that one. Immediately post-operatively, patients may have a lot of pain, which may preclude optimal use of the pacer until the pain is under control. But once they start using it, there's, again, different ways that you can go about utilizing the pacer. So somebody who isn't using non-invasive ventilation and has really very few respiratory symptoms, you might just use it during the day for 5 times, 30 minutes each. Anybody who's having sleep-disordered breathing, or if a patient prefers it, it makes sense to use it at night. Anybody who's using non-invasive ventilation, the idea, the suggestion is that you use diaphragm pacing along with non-invasive ventilation to help continue to stimulate the diaphragm. And then certainly, once somebody has any degree of respiratory instability or more of a respiratory decline, you would want to use it full time. And there is some evidence to suggest that breathing with the diaphragm pacer is going to be better than just their volitional breathing. So, does it work? And I think that's the million-dollar question. Not that I'm going to provide any definitive answers, but I'll show a little bit of the evidence. So this is evidence from Dr. Onders from just his first, I think it was 6 or 7 patients. And what they did was, using ultrasound, looking at the diaphragm, looked at the thickness of the diaphragm before implantation and then afterwards. And the thought being, if you stimulate the diaphragm, improve the bulk, it should be thicker, just like a muscle builder lifting weights. And so this is the left side of the diaphragm before implantation, and the right side, and then this is post. And you can see in each case, the diaphragm became thicker. So it went from 3.9 centimeters to 4.5 centimeters, 3.9 centimeters to 4.8 centimeters. So it looks as though diaphragm pacing is doing something in this group. Again, small number of patients. Ultrasound is, if anybody's had a sonogram when they were pregnant, you know the images are pretty fuzzy. Same thing goes when you're looking at a diaphragm. You're looking at this moving gray line. It is open to some interpretation. This is another slide of those same early group of patients looking, and it's a fairly busy slide, but it's looking at the decline in vital capacity before implantation and after implantation. Each of these lines represents a different patient, and then these are some mathematical extrapolations from those. And again, the idea being that if you condition the diaphragm, perhaps you would slow the decline in diaphragm strength as measured by vital capacity. And you can see the line here is steeper than it is over in this portion, suggesting that after diaphragm pacing was started, the decline of vital capacity slowed. And then this was an extrapolation to say, well, if they continued on this course versus this course, they may actually live 20 months longer. Again, a lot of extrapolation, a lot of mathematical modeling, but some indication that things could be slowed down and the disease course could be altered to some extent. Again, nobody's ever suggested that this is a cure for ALS in any way, but perhaps you can slow down the decline in the progression of weakness of the diaphragm. And then this comes from some of the data that was submitted to the FDA. Again, it was 80-some patients initially. What we were able to do was take 43 of those patients and match them to a group of patients that I had taken care of in the past who used non-invasive ventilation. And so all of these patients used diaphragm pacing along with non-invasive ventilation, so that's the blue line. And the red line is my patients who just used non-invasive ventilation. This is showing survival from the time of ALS diagnosis. And the difference was, on average, this group survived for 21 months after diagnosis, and this group with diaphragm pacing survived for 37 and a half months. So it was 16 months longer survival if they used diaphragm pacing along with non-invasive ventilation. So I don't have time to go into the problems with using what we would call historical controls, so using a different population studied in the past. There's certainly shortcomings. You're not necessarily comparing apples and apples. There's a little bit of an apples and oranges possibility, but at least some evidence, again, to suggest that diaphragm pacing is beneficial over non-invasive ventilation alone. And then a group in Paris have done sleep studies on patients after diaphragm pacing. And I'm just going to focus on the first corner here, showing sleep efficiency. And what they were able to show is that from month 3 to month 7 after diaphragm pacing, sleep efficiency improved. So the amount of time that people were able to sleep in a night got better. So suggesting that if they were having sleep disordered breathing at night, it was improved by diaphragm pacing. Interestingly, they also looked at lung function decline and weren't able to show any change in lung function decline before and after pacing. And I'll just mention in passing a recent study by John Bach that came out just a couple months ago in Muscle and Nerve, comparing patients who had non-invasive ventilation to patients who had diaphragm pacing, and he also wasn't able to show a change in the decline in lung function, although there were also a number of shortcomings in that study. So I think, to wrap things up, only a few minutes over, I think it is a safe intervention, a safe procedure that has really been refined. It shows promise, but I think more research is needed. So the Northeast ALS Consortium is starting a study slated to begin sometime in December or January. Pam Shaw is in the midst of a randomized study. There's a French study that is underway, and I believe there's also a study on the West Coast that is also getting, is at least under planning phases. So I think we're going to learn more about this, but there are many clinical sites up and running that are currently implanting diaphragm pacing. This is just a map of the U.S. showing referral and treatment. So all of the yellow squares are sites that are already using this clinically. So it's kind of an interesting situation we're in, where there's research being done, but there's also people who believe this is a benefit and ought to be doing it. And I'm trying to remain somewhat impartial, and hopefully I gave a balanced view. I will stop there.